The American Cancer Society estimates more than 7,500 people in Hawaii will be diagnosed with cancer this year. The majority of cases will likely be women with breast cancer, but a diagnosis is not a death sentence. Early detection, various treatment options, and preventative measures are part of the arsenal of tools to help overcome this obstacle. Tonight's live broadcast and live stream of insights on PBS Hawaii start now.
Aloha and welcome to Insights on PBS Hawaii. I'm Olena Hugh. The statistics are sobering. About 1 in 8 American women will develop invasive breast cancer over the course of her lifetime. In fact, according to the World Health Organization, breast cancer is now the world's most commonly diagnosed cancer. But experts say treatment can be highly effective, especially if the cancer is found early. Regular screenings, self-exams, genetic counseling, and even preventative surgery could reduce the risk of breast cancer in women. For me, breast cancer has touched my life many times. First, my aunt, my grandmother, and my mother. Now, after my mom passed away from metastatic breast cancer, I tested positive for a genetic mutation. Now, that meant that I not only was at high risk of the disease, but extremely high risk. 2 years ago, I opted to undergo a prophylactic bilateral simple mastectomy, which means I had both of my natural breasts removed without reconstruction, which reduced my chances of breast cancer by over 90%. Tonight, I am honored to be able to share my preventative story tonight, along with discussing how breast cancer has impacted others, how best to prevent the disease, and what treatment is like, what's new with technology, and how you can help. We look forward to your participation in tonight's show. You can email or call in with your questions. You'll also find a live stream of this program at pbshawaii.org and the PBS Hawaii Facebook page. Now on to our guests. Dr. Lisa Grinninger is a surgeon at Kaiser Permanente Moanalua Medical Center. She is a fellow at the American College of Surgeons, a member of the American Society of Breast Surgeons, and has been involved with the Aloha Medical Mission Volunteer Organization for nearly 30 years. Joanne Hayashi was diagnosed with breast cancer in 2015, shortly after she founded the website Breast Cancer Hawaii, and in 2019, she left her corporate job to focus on the nonprofit. She's also a freelance translator for Japanese dramas, manga, and anime. Mary Hickman is a certified genetics counselor who specializes in oncology cancer genetics at the Kapiolani Medical Center for Women and Children. Genetic counseling can help assess individual or family risk for a variety of inherited conditions, including cancer. And Dr. Ryan Nakasone is an MD Anderson certified oncologist and hematologist. He's the Assistant Chief of Oncology Department of the Queens Medical Center and is also an Associate Professor of Medicine at the University of Hawaii. So thank you all for joining us tonight. And of course, with it being Breast Cancer Awareness Month, we really appreciate you taking the time. So my first question, Joanne, I wanted to talk more with you as you are a breast cancer survivor. If you could share with us your story, how that happened, and how it has actually changed your life thereafter as well.
Yeah, it's changed my life is an understatement. But so I was 33 years old. I found a lump in my breast. Mammograms usually only happen for women 40 or 45 and above. And so when I found it, it was already a lump that I could feel. And luckily, my primary care physician took it seriously and sent me immediately to scans. Turns out it was in fact breast cancer and not a cyst, as many young women do get. And so I opted for chemotherapy first to reduce the size of the tumor, then got surgery. I chose a lumpectomy, which is just taking the portion of the tumor out, and then followed by radiation. And when I was diagnosed and when I was going through treatment, it was just very overwhelming. The amount of information, the decisions that you had to make, facing your mortality, making friends with other people who had breast cancer, and then those people passing away. It was just all very overwhelming. And there were a lot of resources and support out there, though. But sifting through that was also overwhelming. And so that's why I started Breast Cancer Hawaii to help reduce that overwhelm for other patients that might be facing the disease.
And so what exactly does Breast Cancer Hawaii do?
Sure. So our mission is to connect people with relevant resources and meaningful support. And so we do that through a number of ways. We have our website where we list a resource library. We recently uploaded a directory of family therapists that have experience with people facing a cancer diagnosis and are accepting new patients currently. And we have educational events as well, where we connect people to information and resources. And then in terms of support, we do one-on-one peer support. And we also have different group events where people can network with other patients and survivors.
That's wonderful, because I've even had those that have been diagnosed with breast cancer reach out to me for support and guidance.
Right.
And so it's very helpful, because I feel oftentimes that they don't know what to do, what their options are. I've had people ask me, why did I decide to have mastectomy?
Right.
And so offering those resources for people is invaluable.
Right.
And so, Mary, I wanted to kind of turn it over to you as a genetics counselor. That was how I had determined to have my surgery, because not only did I have the family history, but I also tested positive for a genetic mutation. Can you explain what it is that you do and what it means if someone does test positive for a genetic mutation?
Of course. So genetic counselors are experts in navigating genetic testing and family health history, because we know that in addition to possible inherited cancer syndromes, family history also plays a huge part in what our risks for developing cancer in our lifetimes are. So when someone meets with a genetic counselor, it's often in the context of having a personal or family history of cancer. We'll discuss certain features that we're looking for that could be more concerning for an inherited syndrome, such as very young ages of onset, or many family members with similar diagnoses, or even some other rare forms of cancer. If somebody elects to undergo genetic testing, and we determine if that's appropriate, either through whether or not testing is indicated, but also if it's a right decision for a person to undergo, because that can illuminate more information about whether or not someone has an heritable risk for cancer. I describe it as one of the barriers in our body that is helping to protect us from developing cancer is in essence broken down. It does not mean that a person will develop cancer, but it helps guide a pathway for what types of screenings or surgeries might be indicated to help lower that risk and make sure that that diagnosis doesn't happen to other people in the family as well.
Can you describe more so what a genetic mutation means?
Of course. So we have thousands of genes that are the instructions for our growth and for our development. A subset of these genes, oncogenes and tumor suppressors, kind of like what they sound like, work to regulate how our cells divide and how they naturally die off. So if these genes aren't working properly, if they have a mutation, kind of like a typo in that genetic code, that's when we can see a person at a higher risk for developing cancer. So all genetic testing is a specialized spell check to look to see if we can identify one of those mutations.
And what types of people are usually at the higher risk?
Some of the common features I look for are very young ages of onset than what we might typically expect to see. Certainly women who are diagnosed with premenopausal breast cancer would benefit from genetic testing. If we see many family members with breast cancer, but also other forms of cancer, ovarian, pancreatic, early onset colorectal cancer, and that's where a genetic counselor comes in to help map out that family tree and look for these patterns that could be suggestive.
And Dr. Grinninger, breast health is obviously your forte. How can a woman distinguish between a lump and a cyst, and what would be your advice to them if they feel like something might be wrong?
Well, generally, if a woman notices something different in her breast, particularly a lump or cyst or something that feels different, it's probably good for her to check with her primary care physician or nurse, or a lot of women go in to see their GYN provider. And often, depending a little bit on the age and the exam, if the woman is around 40, we always look to see if she's had a mammogram or if she's due for a mammogram. Often also for something that is palpable or some type of lump that we can feel, we'll also do an ultrasound, which is really the best way to tell. It sees fluid very well, so cysts, which are very common, are sacs filled with fluid, and we can see those very well by ultrasound. So most of the time, we'll do some sort of imaging as an initial test, basically.
What's the difference between a tumor and a cyst? I mean, I know you mentioned that the cyst could have liquid, and then, what are the steps that are taken when something is said to be a tumor?
Well, when we feel what we call a dominant mass or a lump that really feels different from the rest of the woman's breast tissue, which can be different because a lot of women have what we call fibrocystic changes or just breast tissue that feels kind of more fibrous and lumpy, then generally we'll, like I said, kind of look to see when their mammogram was or if they're due for a mammogram and possibly focus on the area as well as an ultrasound to kind of evaluate the mass or the lump. When we talk about a mass, it's just a term for kind of a lump, basically. And a lot of times what we'd want to do is initially tell if it's fluid, something filled with fluid, which almost always is benign or not cancerous, versus a solid lump, which could be something that could be cancerous, although a lot of those are also benign too, are not cancerous. So it's important to get it checked out. And I think one of the important things to know is most lumps don't turn out to be cancerous. So, it's very frightening to find something. And, we'd want to, if it were cancer, of course, we'd want to catch it as early as possible. But most of the lumps don't turn out to be cancerous. So it's not, there's always so much anxiety involved.
Mm. How does the lump feel different, maybe from regular breast tissue?
If it's smooth, cysts tend to be very round and smooth and kind of move around, whereas cancers in general, when they get to the size where we can feel them, they tend to be harder and kind of a little more irregular. But it's very difficult to tell just by feeling.
Definitely. I remember going to an event in downtown, and I remember there were breasts that you could feel, like the model, right? Mm-hmm. And it was like, if it felt kind of like a marble or like a pea.
Yeah.
That's something good to kind of remember with the self-exams.
Mm-hmm. Yeah.
And so, Dr. Nakasone, you are an oncologist, and so you deal with those that have cancer. And so what are the next steps when someone comes in and, they have breast cancer? And can you also distinguish, what your method of treatment would be if they're stage 1 versus stage 4?
Yeah, so great question. And there's a lot of things that go into making those decisions when we're going to decide which path we're going to put a person on. Like was mentioned earlier, having the diagnosis of breast cancer can be daunting. It can be scary. And so we really do a lot of education, we do a lot of support, and we follow national guidelines and standards of care to determine which way we're going to go with that person. So stage 1, for example, traditionally can be treated with surgery, not necessarily needing chemotherapy, but there's a lot of factors that go into that. And then if it's a lumpectomy, for example, followed by radiation, whereas mastectomy traditionally doesn't necessarily need radiation afterwards. Stage 4, for example, that means the cancer is already spread outside the breast. So a lot of options over there can be things like chemotherapy to try and shrink the cancer, slow the cancer down. We have hormone therapies. So we have different options that we can use to try and attack the cancer from different angles.
Have you, used any newer technology that you'd like to share with us as well?
Yeah, so there's always new therapies coming out that help us in our armamentarium to go against cancer itself. So one of the latest rages now is immunotherapy. And so there are certain roles for using immunotherapy, for example, in breast cancer. And so that's kind of exciting because it gives us an extra option in certain situations that we can employ.
Thank you. And so, Joanne, you mentioned that you opted to have a lumpectomy and then radiation. Mm-hmm. What led you to that decision?
Yeah, so a number of factors. Chemotherapy was hard on my body. And so initially, I was very set on getting a double mastectomy, reconstruction. But then the more that I looked into the different options, I just wanted to do something that was not as hard on my body after I had been through so much during chemotherapy. The doctor also did explain to me the differences in survival rates, which actually were the same between a lumpectomy and a mastectomy. And so if that was the case, I thought maybe, just doing a smaller surgery would be best for me at that time.
And Dr. Greninger, if you could maybe clarify what the difference is between mastectomy and lumpectomy.
Yeah, good question. So mastectomy generally means removing almost all of the breast tissue. There's actually different types of mastectomies we do now. And sometimes it also involves breast reconstruction. So the term mastectomy generally means removing most of the breast tissue, often including the nipple. Whereas lumpectomy typically is just removing a portion of the breast. In general, we like to remove the cancerous tumor plus a little margin of normal tissue around it.
Excellent, thank you. And we're starting to get viewer questions, and so I'd also like to remind everybody, if you have a question, you can call in, you can also Facebook us, and I would be happy to review your question and maybe we'll ask it live on TV. And so this one is actually maybe for Mary. It's from Lori Maka, and she says, we understand that genetic risk are factors, but what do your speakers have to say about environmental or diet and other risk factors, and what can we do to prevent cancer? So I guess this could be a couple of our panelists, perhaps.
I always say from the genetics perspective that it really is just one piece of the puzzle. Individuals who have a gene mutation that puts them at higher risk for breast or other cancers, it doesn't mean that they will develop cancer in their lifetime. It's a combination of genetic factors and our environment. Sometimes that is lifetime exposures to hormones, estrogen and progesterone, and our oncologists and surgeons here can discuss more on that front. But I certainly always encourage healthy lifestyle. I think that all of this contributes significantly. Genetics is not deterministic in that way.
Dr. Nakasone, would you recommend doing things like going vegan, eliminating all sugar from your diet? Have you seen results from those things?
Yeah, it's a great question, and we get that question a lot. Unfortunately, dietary control of cancer is very difficult because a cancer cell is just a normal cell that's gone awry. And so when you try to eliminate something from your diet, your normal cells that also need those things are going to not be able to get the nutrients that they need as well. So dietary control can be very difficult because you cannot select which cells get or do not get a certain nutrient or a sugar, for example.
Excellent. Good to know. All right. We also have another question from Uncle Don from Newtown. He would like to know if it's true that Asian women are more likely to get cancer in the United States than in Asia. And I feel like, in terms of maybe talking about race, there are certain types of races that are more prone to getting breast cancer, and that's something that maybe Mary would like to talk about too.
I can't necessarily speak to, it sounds like that's more of a question towards environment of living in certain areas versus the others, but from a question about our ancestry and race, there are certain genetic mutations that are more common in certain populations. Although our approach now to genetic testing and to that assessment has become what we call pan-ethnic testing, where we're discovering more and more this overlap of who can have gene mutations and where it's more common, that ultimately we take that as a factor into consideration of what we might be concerned or suspicious for, but approach it very similarly for any patient.
And are there different types of breast cancer? Now, obviously there are, different stages, and then also before stage 1 even so, but can one of you speak on, the different types as well?
Well, most of the cancers we see start in what we call the ductal system, the ducts in the breast that carry the milk. So probably about 85% of the breast cancers we see are what we call ductal, either invasive ductal carcinomas or earlier stage ductal carcinoma in situ, and about 15% are from what we call the lobules, the more structural components of the breast. We treat them very similarly. And then there's other very rare tumors that can start in the breast, such as lymphomas and things, but probably the vast majority are what we call invasive ductal carcinoma. We don't know what causes them. It's one of the things that, despite so many years of research and everything, we haven't quite figured out how to prevent breast cancer. So at this point, usually except for, maybe the more like surgical prevention and things like that. But so most of the focus has been on, early detection.
Mm-hmm. I know for me, after I had my mastectomy, they actually said that, if they had detected any cancer within the cells, that they might have to take out my lymph nodes in my armpit. Why would that be?
Well, we know when breast cancer develops, and at some point over time, and it's difficult to tell exactly when, it could potentially spread outside of the breast. And if it does, most of the time the first place it goes to is a lymph node under the arm, or what we call the axillary lymph nodes. So in general, for earlier stage breast cancers, part of the surgical treatment is to do what we call a sentinel lymph node biopsy, or just to identify and test the lymph node that's the breast drains to on that side, just to accurately stage and to make sure there's no spread outside of the breast.
Mm-hmm. Have you noticed any other kind of treatments that are successful other than radiation and chemotherapy?
Well, I do the surgical part, so I would say most of the patients, especially for earlier stage, and even for later stage surgery, is involved at some point. You know, like Dr. Nakasone was mentioning, sometimes, you know, the chemotherapy might be first, depending on the stage. As far as other treatments, there's some, I think, research going on as far as like freezing tumors or ablating them with lasers, or other types of treatments. But at this point, those are kind of all in the experimental phase.
Wow, interesting.
Yeah.
Anything you want to add, Dr. Nakasone?
Yeah, Dr. Grinninger is 100% correctly. I mean, the three main pillars of treating cancer in general is surgery, and in early stage breast cancer, surgery is absolutely pivotal. And then radiation, and our radiation techniques have gotten better. They use different types of machinery now that they can localize tumors better and decrease the side effects from the radiation itself. And then our systemic therapy, so things like chemotherapy and hormone therapy. So those tend to be the three pillars of treating breast cancer, and some people get all three, some people only get two, again, really depending on the type of cancer and the stage.
And how do you go about recommending which one is best for them? And also, how do you address the issue of hair loss? I know that can be a concern for some people.
Definitely. You know, hair loss is a very tangible thing that people see when they're getting treatment, and it's just very visceral and very visual. And so it can be very impactful in terms of how they feel and how they kind of perceive what they're going through. So we definitely tell them that certain medications, like certain chemotherapy drugs, does have unfortunate side effects of hair loss, but the majority will come back, and we tell them wear it like a badge of honor, right? It's just showing that you're fighting this disease and you are fighting for your life. You know, so it's important that they try to turn it into a positive, that they're going through this thing together with other people around them as well.
I know a lot of people feel concerned that if there's a family history of other types of cancers, that they might be at risk as well. And can you speak on if that would be accurate? Like, I had someone tell me, oh, my uncle had colon cancer, so she assumed that she might be at risk of breast cancer. Is there any correlation between the two?
So when we first meet a patient in consultation, we try to take a very thorough family history. So we can try to screen for clues that may point us in the direction that they may have a genetic underlying cause for their malignancies. So we ask who in their families had cancer, how old were they when they had the cancer, what type of cancer did they have? And we put it into a rubric to help us decide if we feel they do have a high risk of having a genetic abnormality, and then we send them to genetic counseling and get the genetic testing. So we definitely try to screen people for that possibility.
And Joanne, for you, did you have any family history of cancer?
We do have some family history of cancer, but it wasn't anything out of the expected age range. But because, as Mary had mentioned, I was premenopausal, genetic counseling and then testing was definitely recommended for me. And that was actually one of the factors that went into me deciding on a lumpectomy, because the risk profile was specific to me not having a genetic mutation, because if I did, then I would have gone for the mastectomy route.
And what do a lot of women ask you when they come to you for guidance?
Am I going to be okay? How bad is chemotherapy? And, it really depends. I said earlier that it was kind of hard for me. I have friends who worked through their chemotherapy. And so it really differs by person on how how much they can tolerate. One thing that I do advise people, though, is to definitely reach out for support. And if people are offering it to you, take it. That is something that I tell people.
One thing that impressed me about my mom was that she was driving herself from Kilauea on Kauai to Wilcox Hospital for her treatments, all the way up until the end. And if you're from Kauai, you know that's really far. Okay, so we do have a few more questions coming in. This one's a little technical. Please have the guests talk about the different types of breast cancer, which we kind of did, but this one wants us to focus on triple negative. So Dr. Nakasone, perhaps?
Yeah, so like we alluded to earlier, there's different types of breast cancer. And we look at the cell architecture to determine if it's a ductal carcinoma versus a lobular carcinoma. But on the surface of those cells are certain types of receptors and hormone receptors. And about 80% of breast cancers traditionally are hormone positive, what we call ER/PR positive. And that means that they will be sensitive to hormone medications that we can use to try and fight the cancer itself. Triple negative is a form of breast cancer which they are negative for all three of our traditional markers that we test for on the surface of the cell. So they're ER negative, PR negative, and what's called HER2 negative as well. It is one of the more rarer forms of breast cancer. It's only about 10 to 15% of breast cancers tend to be triple negative. However, it can be a more aggressive form of breast cancer as well. And unfortunately, it does limit us in terms of some therapeutic options, because if they don't have these receptors, we cannot use certain medications that target those receptors.
And we also have another question coming in from a viewer, Mike in Kahului. He said, it's kind of a statement, but I encourage people facing cancer to get genetic testing, as well as seeing a psychologist to manage anger, stress, depression, and PTSD. A sense of humor and deep breathing also helps. And so, Mary, I wanted to ask you, obviously this person is recommending genetic testing. How important is it to get genetic testing if you're already diagnosed with cancer?
Yes, I think that is something that comes up with many of my patients, because I would say a majority of my patients have already had cancer. And one of the most frequent consults that I have are actually with women who have been recently diagnosed with breast cancer. So people who have had cancer are actually some of the most important people to get genetic testing for multiple reasons. The first is that sometimes it can help to impact treatment and options in terms of surgery, radiation, and other interventions. The second is that a person who has had cancer is the most ideal individual in a family to get testing, because if we can rule in or rule out that their cancer was caused by a gene mutation, that's even more informative for family members who have never had cancer as to whether or not they should get testing. Because if we can determine that someone who has cancer has a gene mutation that caused it, and let's say their children all test negative for that gene mutation, and there is a chance that parents can't pass that down to their children, then what that means is that their kids don't carry that familial risk for cancer that their parent might have.
Can you take us through the process of genetics testing, what the person is providing and what's being tested, and then how long until you get the results?
Of course. So a general overview of the process is when I meet with a patient, we go through a detailed medical history and family history, where I'll ask about relatives up to grandparents' generation, aunts and uncles, cousins, children, and asking about their ages and if they've ever had cancer. From there, based on some of the patterns or indications that we're seeing, we'll discuss whether or not it's indicated that we should consider genetic testing. In some cases, genetic testing is not indicated, but we still talk about that option. It's actually become much more accessible and affordable in recent history. We use that information to determine if genetic testing is something that a patient would want to do. I feel that many of my patients decline for reasons that it's not a guarantee they'll develop cancer. It's not a guarantee that they'll have a gene mutation, and some people don't want that information. So I help in that shared decision making, and that's where the counseling comes in, to make sure that they're fully informed about the process, make sure that they feel comfortable moving forward. Now, genetic testing is pretty painless. It's just a blood draw or a saliva swab, and in about 2 weeks, I'm the one who will disclose those results.
And we also have news coming out of the UH Cancer Center. They recently released results from a study that said artificial intelligence could improve risk assessment to help with early detection. Do you think that AI could one day play a significant role in improving detection of breast cancer as well?
I think that there's a couple of companies who have already released AI technology or things like chatbots where people can input some of that history. And based on specific criteria that we use to determine if you meet testing criteria, I think that's really what the AI models are doing, is plugging it into a formula to determine if those checkboxes are met. I would say there certainly is a little more nuance to it, but there is a benefit in terms of access for people who maybe don't have genetics providers in their areas. I will say that we are trying to expand resources in Hawaii. We provide telemedicine services across neighbor islands, and so it's something that if we can do this in person and outreach, that's the goal. But I think there is a purpose for it.
And Dr. Grinninger, we've heard mainly about women with breast cancer. Do men get breast cancer too? Do you have any male patients?
I have a few male patients. About 1% of breast cancers occur in men, so that's a very good point. There's not any screening, that's recommended for men, but definitely, if a man notices a lump in his chest or breast, it's good to see his physician or nurse practitioner to have it checked. There are a fair number of benign lumps that can occur in men as well. There's something called gynecomastia that is actually more common than breast cancer in men. So finding a lump doesn't mean he automatically has breast cancer, but it's a good point to get checked out. Mm-hmm. And then pretty much, I think any man who has breast cancer is generally recommended to have genetic testing because it is something that could be passed on to, say, his daughters and that kind of.
How do they usually find it? They just noticed a lump in the area?
Yeah, almost always just a lump.
Wow. And when do you guys recommend ladies or, possibly men get more testing? And for women, perhaps starting mammogram? It's 40 years old, right?
Yeah, most organizations recommend starting they'll say every 1 to 2 years at age 40. There are a few that recommend starting at age 50, but I think the American Cancer Society and American College of OBGYN pretty much all recommend starting at age 40, with some exceptions. If there's some very young women in the family that have had breast cancer, sometimes we'll start a bit earlier.
We also have a question coming in from Carol from Pearl City. She says, does a mammogram really detect very well? And what condition would need a 3D scan to be detected? And then we were all talking about this earlier, not Ryan, though, Dr. Nuxtoni, but we have all had mammograms and talked about how uncomfortable it can be. And we experienced the 3D one as well. But yeah, how good is that? And does the mammogram do a good job?
Well, the mammogram is really the best screening test we have, meaning to go in, once a year, check both breasts. They do 2 views, and that alone will catch probably 85 to 90% of breast cancers. It still involves, some compression and it's uncomfortable, but it's really the only test that's ever been shown in the United States and across the world to actually decrease the number of women dying from breast cancer. And there's very good data that they're very effective. It's not perfect, so it's also important for a woman to know if she does notice a lump, even if she's had a mammogram kind of recently that was negative, it's still good to get it checked out. A lot of women say, well, can I do ultrasound rather than mammogram because it doesn't involve the compression? And there's some studies looking at screening ultrasounds, but at this point it's one of the problems with ultrasound is it's almost too sensitive. So when you just look all over, both breasts with ultrasound, and some of the studies, about 30% of the time you find something that's questionable that leads to a biopsy, and most of those are negative. So the mammogram is really the best screening test we have. It does involve some compression, but most of the time it's pretty fast and hopefully worthwhile.
And sometimes they're done together where you have, if there's something that you're trying to find. And then for me, with my high detection plan, I was alternating mammogram and either ultrasound or breast MRI every 6 months. Mm-hmm. And so that was, I was doing that for like maybe 7 years. Do you find that that's also a good thing to do?
For women that are considered at high risk, and some include the women who, with known genetic mutations. The MRIs are often recommended, once a year for women considered at very high risk. In general, a lot of organizations will say if a woman's estimated lifetime risk is 20% or higher based on statistical models or genetic testing, that it's worthwhile to have a mammogram, an MRI once a year in addition to a mammogram. Ultrasounds in general are usually more what we call targeted studies, where you're looking at possibly an abnormal area on a mammogram or something questionable on an MRI to look at that specific spot to get more information, or a lump that you can feel.
And I think it's important to recognize that you're doing these things because you're trying to find out what's in there. It's taking a look inside the body to try to identify what's going on. And so for people to kind of acknowledge that, oh, I don't really know what's going on. There might be something in there. Let's just take a look. It's not, it might not be anything, which oftentimes is the case.
Yeah.
And so we have a comment from Sam, and he says, or she says, we have a family member whose cancer treatment of chemotherapy and immunotherapy cost $30,000 a month. Most is paid for by insurance, but why does it cost so much? Dr. Nakasone, perhaps?
I wish I had an easy answer for that. I mean, they do put in a lot of money into the research and development of all these new agents, but the cost can be prohibitive for many people, unfortunately. And so there's foundations that we can try to apply patients to try and defer some of that cost. Some people can even get free drugs, depending on their income, et cetera. But the price of drugs can be quite considerable.
We have another question from a viewer. What are the chances of getting breast cancer again after being 15 years free of it? Dr. Nakasone.
So we usually use 5 years as a big milestone. When somebody reaches 5 years out from their original cancer diagnosis, the chance of that cancer coming back is very low. Unfortunately, we tend to think it will never be, technically zero. People, once you have a cancer, your body's done something abnormal, and so there's always a risk that you can manifest a second cancer or even a new cancer in a different organ as you get older. So there is always going to be a risk of a potential recurrence of the cancer, but it does get less the further out you go. So 15 years, for example, is outstanding, and the chance of that cancer coming back is going to be very, very low.
And we also have other questions coming in. What's the most common age range of breast cancer? And then would a patient of 80 years be treated the same as a person of 50 years old? Dr. Nakasone.
Oh, sorry. So we do tend to see breast cancer more commonly in women maybe in their 50s, 60s, and 70s, for example. We don't use age necessarily as a hard and fast rule about what types of therapies somebody's going to get. We really have to look at them as a whole picture. We take age into account, of course, but we take how well they're functioning, their other health issues, and we try to assess and figure out which therapies they can and cannot tolerate and how aggressive we can be. We try to apply the same therapeutic structure to every patient, whether it's surgery, chemotherapy, radiation, but the question is, do we feel that patient can tolerate those things?
Okay, thank you. We have a comment from Ruth from Makiki, and thank you so much for sharing, Ruth. She said that she had stage 4 breast cancer and switched to a vegan diet per Dr. John McDougall's research, and she's been cancer-free since having surgery. So congratulations to Ruth. Have you seen that also, where, going vegan or, changes like that can help?
I mean, I think a lot of people are motivated to make healthy changes in their, whether it's, exercise or a more healthier diet. There's not a real specific diet that I think works for everyone, and we don't have good medical evidence that any specific supplement or diet will treat breast cancer. I guess one of the things after menopause, as we've mentioned, a lot of the breast cancers are what we call estrogen receptor positive or estrogen sensitive. So before menopause, most of the estrogen in our bodies comes from our ovaries. And after menopause, most of the estrogen body comes from our body fat stores and adrenal glands. So after menopause, kind of having more normal weight, there's, compared to women who are overweight, there's more estrogen circulating. So that's one change that we can make to help decrease our risk of breast cancer.
Jamie from Honolulu writes to us saying, regarding dense breast tissue, do the doctors recommend further evaluation through an ultrasound, or should you just wait for your next annual mammogram?
Well, when women have mammograms, generally part of the report is just a remark about the density of the breast tissue, and dense breasts are very, very common. So generally, the once-a-year mammogram is probably the best screening tool. I think now there's what they call 3D mammograms, which are becoming more available, and having the mammogram is the same, so you don't feel any different having a 3D mammogram, but the software is able to do more detailed calculations, so they seem to be a bit better at detecting masses in dense breasts. So that's something that's probably worthwhile asking about.
And Dr. Nakasone, we have another question from a viewer, Heidi from Kauai. She says, please address HER3 positive result, and also please talk about the different side effects of breast cancer treatments.
Great question. So when I alluded to earlier, when I talked about the different receptors on the cell surface of these cancers, one of the receptors is called HER2. And so it is a target that we can use for certain therapies. There is data that shows that HER2 tumors do often tend to be more aggressive. And so we definitely want to treat them aggressively. And so we add HER2 targeted therapy to the chemotherapy to try and make the recipe more aggressive when we try to attack those tumors with chemotherapy. In terms of side effects and toxicities, it really is specific per person. There are people who can tolerate chemotherapy pretty well, where they just have some fatigue, but they're still working. And there are unfortunately some people who are just very sensitive to chemotherapy, where they have nausea, vomiting, decreased appetite, weight loss. So it really can be personalized per person depending on the recipe that they get and their sensitivity, how well they can tolerate the chemotherapy.
And Joanne, you spoke about it a little bit before, but you did chemotherapy and radiation. And how did both affect you? And you said you did chemotherapy first, right?
I did, yep. So I did chemotherapy first to try to reduce the size of my tumor, which gave me the option for the lumpectomy. Chemotherapy really was, I was one of those that did not tolerate it well. And so by the time I got to everything else seemed like a cakewalk compared to, the initial chemotherapy. But there are medication and different interventions that can help with the different side effects. I really don't want people to be scared of the side effects because, the doctors and other specialists can help with all of those different side effects. You just need to make sure you communicate with your doctors about them as you face them, yeah.
And you've been cancer-free for how long now?
I've been cancer-free for 5 years. Yeah, I was diagnosed in 2015, so.
What kind of things do you do now in terms of trying to spread the message of your experience and share your story?
Sure. So, I come to opportunities like this for sure. We also, through Breast Cancer Hawaii, we share stories of survivors. We reach out to the community in different circles. Next week, I'm going to be speaking to Public Health Club at the University of Hawaii. But any opportunity where there might be people that have been impacted by cancer, which is a lot of people, even if you yourself have not been diagnosed with cancer, you're usually touched by somebody who has been. And so to be able to support your friend or family member, we try to educate the general public about the resources and support that's out there.
Talking a little bit more about support for caregivers, what kind of advice do you have for them?
So for caregivers, I know that some caregivers go through a period of guilt because they feel like maybe they should have had the cancer or, that they're not the ones that are sick. So they take on more and don't maybe sometimes process it openly as much as maybe the patient does. Sometimes the patient's very open about their diagnosis. the caregiver does need a lot of support. And so if you're friends or family members of the caregiver, I would encourage those people around them to please support the caregiver as well too, because they also need the emotional support so that they can then support the patient in treatment.
Absolutely. I remember after my mastectomy, I don't remember how much time had passed, but my husband said, "I'm not going to baby you anymore. You have to do this and that now on your own." And I was like, oh, okay. After I'd watched everything on Netflix. So Mary, I also wanted to kind of send it over to you to explain a little bit more. People seem to know more about the BRCA or BRCK mutations. And then for myself, I was diagnosed with RAD50. And so can you kind of differentiate between those and what they mean?
Of course. So we have thousands of individual genes which code for proteins that make functions in our bodies. And the BRCA1 and BRCA2, or more commonly known as BRCA genes, were actually some of the first genes discovered that we know are associated with hereditary breast cancer, but also hereditary ovarian cancer. And we can see other forms of cancer from a single gene mutation like prostate, pancreatic, and melanoma. Beyond just the BRCA genes, though, we've discovered that there's many other genes that overlap with breast cancer risk, but that can also increase the risk for cancers in other parts of the body, which is another reason why it's so important for people who have already had cancer to consider testing, because they could be at risk for cancers in other parts of their body. But now we actually recommend that, I believe it's prior to 2013, if someone had BRCA testing, they should maybe consider going in for genetic counseling again and further testing, because there are new genes that we've discovered associated with breast cancer. Maybe they tested negative in the past, but there's something else that could explain the family history. And so this even goes beyond breast cancer. There are inherited colorectal cancer syndromes, pancreatic cancer syndromes, and the list goes on. So this really, the conversation extends beyond BRCA and breast cancer as well.
How does someone get to see a genetics counselor?
Yes, so if they've been diagnosed with a cancer, typically they can get a referral from their oncologist. But if someone knows that they have a strong family history or would like to talk to a genetic counselor to determine if their family history is concerning, they're usually their primary care. A lot of women are referred from their gynecologists. Any physician that they can ask to refer to genetics, they can evaluate, do a rudimentary family history, and determine if it's appropriate.
And it's a really nice way, it's almost like having a therapist to kind of counsel you on what's happening and its impact and give you the numbers. So Dr. Greninger, they called it the Angelina Jolie effect, right? When she was very proactive, her mom having breast cancer, she tested positive for a genetic mutation, and then she decided to have prophylactic or preventative surgery by removing her breasts. Did you see an increase in those seeking to have the prophylactic surgery?
I think definitely. I mean, she was very public about it, and I think after that, a lot more women were aware, a lot more women were asking, is that something they'd even consider? I think a lot more women actually went to genetic counselors as well. And also around that time, I think the field of genetics was really almost exploding. So much more information was coming in. And I think what also was going on at the time is, as for women who are interested in breast reconstruction, the techniques have, it's still not perfect, but have gotten much better, and it's always a very personal choice. Women kind of taking that step to decide they want to have the surgery, and then whether or not they'd want to do reconstruction. But I think the whole field of, it's still, despite all the research and knowledge we have, it's for preventing breast cancer, it's still probably one of the best tools that we have. So it is something I think we're seeing more and more of.
Mm-hmm. And do you find that, when they want to come in for preventative surgery, they want to have reconstruction most of the time? And how often are they willing to just go flat, or, what do you hear?
Yeah, that's a good question. There's so many options. And, we work closely with our plastic surgeons when women are just initially considering or thinking about it. So we have them meet with, usually in our clinic with the plastic surgeons, just to kind of find out what the options are, what surgeries are available, what types of reconstruction. And some women do choose to go flat, and and that if that's the choice, we want to make sure that's done very well, and then there's also a lot of women I've seen recently. There's some really amazing tattoo artists that have, that's an option as well.
You can have flowers, you can have things that look like nipples. And so Dr. Nakasone, talking a little bit more about treatment, if a woman undergoes mastectomy, how does that affect your treatment? And tell me about the steps.
Sure. So mastectomy for early stage breast cancers, right, tends to be the curative step in the management of the breast cancer. So sometimes the patient doesn't really even need chemotherapy afterward. If they tend to be hormone positive, then we tend to give them hormone therapy for 5 to 10 years, depending on a bunch of different risk factors. The only thing we need to wait for mastectomy is basically the healing. So we try to give about 4 weeks to 6 weeks after the surgery for the incisions to heal before we begin, if they do need chemotherapy, for example, to begin the chemotherapy.
Thank you. And Dr. Greninger, also for those that receive mastectomy, do they still have to get mammograms?
Generally not on the side that had the mastectomy. If they've had a mastectomy on one side, then we still recommend doing a yearly mammogram on the opposite breast. But no, if women have had a mastectomy, and some women are like, yay, no more mammograms. I mean, that's one thing to consider.
Absolutely. And Joanne, how are you doing as far as, what you're doing to try to detect cancer as things move forward for you?
Sure. So one thing is that I'm very aware of changes in my breast, so that if there are any changes in size or any additional lumps or redness, itching, because lumps aren't the only signs of breast cancer. And so I'm aware of what the signs are. And then if there is anything that I'm concerned about, I do reach out to my doctor.
And then how often are you going in for mammograms?
So since I passed my 5 years, it's now yearly. But I do also, in addition, I do get MRIs in between as well.
Okay, and we just got our last question from our viewer, a question for Mary. Can tests like 23andMe and Ancestry tell us more about our breast cancer risk as well?
This is an excellent question that I get very often. I think that tests like 23andMe and Ancestry are very fun for that ancestry side of things. But in terms of clinical genetics and better understanding our risk for cancer, unfortunately, those tests are not comprehensive. There are a couple of specific mutations that are targeted of the BRCA genes in those tests, but it's sort of like just looking for single spelling changes, 3 specific spelling changes, rather than reading through the entire chapter of our genetic book. So I really recommend that even if you've had genetic testing through 23andMe that said you were BRCA negative, it's not comprehensive, and I would recommend that if you qualify to consider genetics.
Have you ever used Everlywell or had anybody use an Everlywell test as well?
I actually have not. No, I haven't experienced that.
They're not that bad when it comes to food allergies or food sensitivities.
I've heard that, yes.
Well, we're going to be wrapping up our show in a few moments, and thank you all for joining us this evening. It's been a wealth of information. I wanted to ask a few of you for a closing statement, and so Joanne, what is it that you'd like some of our viewers to take away from watching today?
Sure. Well, if you are diagnosed with cancer, I would, let you know that you're not alone. There's so many of us that are here waiting, ready to support. And so please do reach out for support and for resources.
And Dr. Greninger, how about for you?
Yeah, well, I think Joanne's message is very powerful. I think, for women to kind of be aware of their breasts, be aware of any changes, and get your mammograms. The screening ones are free. So that's...
Thank you. And Mary?
Talk to your family. There's a bit of a stigma and embarrassment sometimes around being diagnosed with cancer, or fear of sharing that. But because we know family history has such a huge impact on our relatives' care and what type of screening might be recommended, open communication between family members is key in prevention.
How do you recommend that they, approach family members to try to find out history?
November is actually Family Health History Month, so if we're sitting down at a dinner table and want to open that conversation, it's never easy. But saying that it can have an effect on your care, hey Mom, I heard that you went through something difficult in the past. Can you tell me more about it? I want to make sure that I'm being protected and doing everything that I can. That can open the conversation in the door.
Thank you. And Dr. Nakasone, real quick, any last message you want to send?
Just like everybody else has been saying, early detection is truly key. And there are many resources out there, many wonderful people out there who can help you work your way through this crazy time of trying to diagnose if you have a lump and you think you might have breast cancer, for example. So, I mean, there's many different resources out there. Queens Women's Health, for example, I mean, there are nurses there, the staff there are amazing. Please just go get checked. Early detection really is the key to try and beat the cancer early.
Absolutely. Well, thank you all for joining us tonight. It's been a pleasure. And we'd like to thank our guests, Dr. Lisa Greninger, surgeon at Kaiser Permanente Moanalua Medical Center, president of Breast Cancer Hawaii, Joanne Hayashi, genetics counselor at Kapiolani Medical Center, Women and Children, Mary Hickman, and Dr. Ryan Nakasone, assistant chief of oncology department at the Queens Medical Center. Next week on Insights, it's something that happens every decade, reapportionment, using population numbers from the most recent census. We'll look at what election districts could be redrawn across the state. Please join us then. I'm Elena Hugh for Insights on PBS Hawaii. Ahui ho.